So a lot of patients in your practice you would have seen comes complaining of chest pain. So how do we evaluate these patients? What is the risk and what should be the investigating modalities to tackle these patients?
I think as clinical cardiologists, we see a lot of patients presenting with chest discomfort. So the first question you ask yourself before you do anything is, what is the pre-test, before any test is done, likelihood of coronary artery disease? And so if that pre-test likelihood is very low, and we take a cutoff of 15%, we don't do anything.
Okay.
The likelihood that he has coronary disease is very low, so we do lifestyle modification. If the likelihood is very high, we take a cutoff of 85%. We send the patient directly to angiography. The likelihood that he has significant coronary artery disease is very high, and he needs probably revascularization. It's the patients in the intermediate pretest likelihood, which is between 15 and 85%, where we do a test. If it is lower intermediate likelihood, which is 15 to 50%, 50, then we do a CT scan because we want to include or exclude atherosclerosis of the coronary arteries. If it is intermediate higher, which is 15 to 85 pretest likelihood, then we do a nuclear scan or we do a stress echo, and we do that because we assume the patient will have coronary artery disease, but we want to know if he has ischemia. So based on the pretest likelihood, we can probably treat well the patient. Your question is going to be probably, how do we determine
the likelihood? True, because that's going to be for physicians across the country, they should understand the likelihood. Based on that, they will approach the patient. True.
That is the key question. Of course, everything is relative, but we have at the European Society of Cardiology a guideline on stable coronary artery disease management, and there is a simple, very simple pretest likelihood calculator that comes from literature, and it was put together by this guidelines team.
Okay.
So what does this calculator include? It includes your age, it includes the gender, and it includes the type of complaints. And based on those three, you calculate the pretest likelihood.
This calculator will give us a percentage?
It gives you the percentage, and based on that you can apply what I just said.
So there are lots of ischemic tests which are available, like SPECT, stress echo, exercise ECG. So how do we pick up the test? Which one will suit a patient best? So, or any one of them will be equally good?
There is differences in tests. We know that an exercise test has a lesser accuracy than an imaging test, but you need to also look what you have at home.
True.
If you have limited resources, if the budgets are limited, an exercise test is what you do. If the budgets are more far-reaching, or if the availability is more, or what's also important, the experience of the people at your home, the physicians, what do they work with the most? If that's more advanced, then probably you like to do an imaging test. In my opinion, a stress echo or a nuclear imaging test, because these are the two most often used, basically have more or less equal accuracy for include or exclude coronary artery disease.
So who are the patients for invasive diagnostic procedures?
Yeah, so we spoke about the first algorithm is pre-test and post-test likelihood. Now you're asking me, if we've done a test,
True.
what is then their risk? So we speak about low-risk patients, we speak about intermediate risk patients, and we speak about high-risk patients. So let's first assume that we've done a CT scan. Okay, a low risk means a normal CT scan or minimal abnormalities, minimal plaque formation.
True.
A high risk scan actually means a patient that has either left main disease or significant stenosis in the proximal coronary artery, mainly the LID, or severe triple vessel disease. That's a high risk CT scan. If you have done, let's say, a stress echo or a nuclear test or even an MRI test, any ischemia test, we look at the percentage of the total left ventricle that displays ischemia. And the cutoff that's taken is 10%. Why the 10%? Because Dan Berman's group in Cedars-Sinai in the United States have shown very, very nicely that if you have more ischemia than 10%, you're better off with the intervention, whereas you have less than 10% ischemia, you're better off with medical management.
Okay.
So for CT scan, you know now the low and high risk,
True.
and for a nuclear scan or a stress echo, the high risk, what I just explained, more than 10%, the low risk is nothing, no ischemia. And the intermediate is what's in between the two.
True. So any other message you would like to give to physicians of India? Like, we are a country now who have evolved from infectious diseases to non-communicable diseases. And hypertension, cardiovascular disorders, stable angina are some of the key bigger problems in India we are facing. So on the preventive aspect, how can as a country we work on to tackle this larger problem?
Well, I think what is important is Dr. Yusuf's talk during this session was very enlightening. He emphasized the fact that the lifestyle often is not good. People have a sedentary lifestyle.
Sure.
The glucose intake is high, smoking is high,
Salt
obesity,
intake itself is
salt
high.
intake. So these things are all pretty high here. So lifestyle education could already make a big difference. The second thing Dr. Yusuf showed is that the use of certain preventive medications, mostly targeting high cholesterol or high blood pressure, or the combination of those two.
Do you agree to that preventive multi-pill or polypill therapy to be given to all?
Well, I think we have to determine exactly who needs what, but his data and his new study that he's going to do is going to bring us a lot of answers to that. I personally believe that if you want to aggressively attack coronary artery disease, that it is important to work on those two risk factors aggressively, that you can only influence with medication mostly at a certain level. So this is high cholesterol or high blood pressure. And then you can fill in yourself which sort of medications we need for that.
True.
But this is very important in lowering the cardiovascular risk and cardiovascular mortality.
I think lifestyle measures should be the bottom line. Like, as a country, we need to resort to better lifestyle, improve our physical activity, resort to healthy eating. Probably that will go a long way in reducing the disease burden for the country.
Absolutely. Yeah.
Thanks for joining today, Bax. Pain. So how do we evaluate these patients? What is the risk and what should be the investigating modalities to tackle these